Welcome to Medical Logistics 101, Sore Throat, Danger Signs to Never Ignore. Today we will be reviewing pharyngitis. This video is for educational purposes only. It is not medical advice, does not replace a medical evaluation, and may not apply to your situation. If you have symptoms or concerns, please speak with a licensed healthcare professional. My goal is to help patients enter healthcare with a map instead of a blindfold, and to explain how clinicians think through these problems in resource-limited settings. Definitions: sore throat or pharyngitis is inflammation of the pharynx and surrounding tissues, commonly caused by viral infections, but also caused by bacteria, allergic, environmental, or mechanical irritants. Signs and symptoms: pain with swallowing, that's kind of the hallmark symptom, scratchy or raw throat sensation, a hoarse voice, cough, more common with viral etiologies, fever, swollen lymph nodes, particularly in the anterior cervical part of the neck, runny nose, congestion, usually viral causes with that. Headache, malaise, fatigue are also sometimes seen. Physical exam findings: the oropharynx or the back of the throat, or erythema, exudates, petechiae, sometimes seen. Tonsils, you may see enlargement, asymmetry, sometimes see exudates with those. The uvula may be midline or deviated. The neck, tender cervical lymphadenopathy on palpation. The voice, you can see what's sometimes called a hopitative voice, which is just kind of a muffled voice sound. It is somewhat of a concerning finding if you see it. Airway, stridor, drooling, difficulty handling secretions, any of those would be very significant red flags. Skin, sometimes you'll see a scarlatiniform rash, which would suggest strep as a possible culprit. Differential diagnosis. Viral pharyngitis is the most common, of course. The bacterial cause of pharyngitis, group A strep, is also very common. Mononucleosis, peritonsillar abscess, epiglottitis, not seen as much anymore, but a very serious cause of sore throat if it's present. Allergic, postnasal drip irritation. GERD or gastroesophageal reflux related throat irritation, very common these days. And of course, environmental irritants such as smoke or dry air. Diagnostic studies, certainly rapid strep test is where we start. The gold standard, of course, is a throat culture, but typically it's done if the rapid is negative and you still have a strong suspicion of strep. Monospot or Epstein-Barr virus panel. Again, mono in our younger patients particularly, you have to be on guard against, particularly if their symptoms are atypical. CBC, if there's systemic symptoms. CT scan of the neck with contrast, not typically done, but if you suspected a deep space infection in the neck, that would be an appropriate test. And lateral neck x-rays, rarely used anymore, mainly was done if you were concerned for epiglottitis. Red flags: drooling or inability to swallow, stridor, muffled hopitative voice as mentioned previously, neck stiffness or severe unilateral throat pain, trismus or inability to fully open the mouth. I have seen that a few times, and certainly that is concerning if you find that. Deviation of the uvula when you examine the back of the throat, toxic appearance or high fever, rapidly worsening symptoms. All these would be red flags for me. Pitfalls: assuming all sore throats are viral, missing peritonsillar abscess, overlooking mononucleosis, which probably happens fairly often, missing early epiglottitis. This is, again, not a common cause of sore throats, but if it's present, it's something you really need to catch early. Typically, those patients will present with what's their neck in what's called a sniffing position or extended. It's really just the patient opening their airway, and it can result in airway compromise, so it's very important to catch it. Missing early signs of airway compromise, like epiglottitis. Forgetting that GERD and postnasal drip can mimic infection, very common causes. Disposition: usually home care for a stable airway and mild symptoms, whether it's viral or bacterial. Follow up if symptoms persist beyond the expected viral course or they're not responding to the oral antibiotics in the treatment of the bacterial causes like strep throat. And even if patients have received an IM injection of antibiotics, again, you should see marked improvement within 48 hours. Urgent evaluation for any red flags. ENT referral for recurrent tonsillitis or suspected abscess. Obviously the ER if there are any airway concerns. Return precautions and precautions that I give patients that they would need urgent reevaluation would be worsening pain, fever, drooling, breathing difficulty, neck swelling, inability to swallow fluids. I would say those patients should be evaluated in the ER. In closing, if this is the kind of content you find helpful, please like and subscribe. If there are topics you would like to see covered, You can email me at medicallogistics101@gmail.com. Remember, the danger isn't always what you know, but rather what you can't afford to miss. Thank you.